Eric, can you hear me?
Yes, I can hear you.
Okay, good. Good morning, ladies and gentlemen. Welcome to the online grand round of the Department of Surgery. For better meeting quality, please turn off your video and the audio during the lecture. We are going to have more than 100 audience, including visiting staff, residents, and the PGY. Now, I am honored to introduce our speaker, Professor Eric Ley, who comes from Cedars Sinai Medical Center in the United States. Dr. Ley is the Professor of Surgery, Health Science Clinical Professor of UCLA, Medical Director of CQ, and the Program Director of Cedars Sinai Trauma and Critical Care Fellowship. Dr. Ley has committed to patient safety in trauma and surgical critical care. He has outstanding achievement and rich publication in this professional field. Dr. Ley is also my mentor when I visited Cedars Sinai 1 year ago. I really appreciate his support and the guidance in surgical critical care. He gave me a lot of opportunity to explore the clinical and the academic area. And as a good friend, he always has time to listen and chat with me. I really appreciate it. Nowadays, Taiwan has increased local COVID cases and the mortality rate is rising. It is really a tough time for Taiwanese people. And in this difficult time, we sense the American support for Taiwan. I think every crowd has a silver lining. I believe we will go through the storm again. This April, there was a train crash in Taiwan that made a terrible disaster. On the behalf of Taiwanese, I said to Dr. Ley's concern at that time, how to avoid this event from happening again. I think the solution may be the human factor research. Now, the time is Tuesday, 4:30 p.m. in Los Angeles. Dr. Ley is going to lecture on human factor in surgery. By the way, Dr. Ley declined the stipend of the lecture. We all appreciate it. With the Professor Xie, the chief of our Department of Surgery, will you give us a short opening?
Hi, Eric. It's fantastic to have you here. Tino had 1 year's fellowship at your excellent team, and he's doing very well after he came back to Taiwan. I think that's all because of your support, great support. So we are very, very excited for your today's great speech. Thank you here. Thank you.
Okay, perfect. Let's warmly welcome Dr. Ley again. Eric, your turn. Please share your PPT. Thank you.
Thank you, Dr. Dino. I'll bring up my PowerPoint now. And I just wanted to thank Professor Xie and Superintendent Xi Wang for collaborating with Cedars Sinai and sending us Dr. Tino because it really facilitates collaborations like this. Tino, can you see my screen?
Yes. Yes. Perfect.
You see the point? Great. So let's get started here. I think we'll have a very informative 45 minutes of lecture followed by a question and answer period where we can expand on some of the topics. I need to acknowledge my disclosures. This research was funded by the Department of Defense of the United States. My chair, Bruce Wertz, PI. I'm the co-editor of the Human Factors textbook. Broadcasting from Los Angeles, California. It's about 4:30 p.m. as Tino said. If you're ever in California or Los Angeles, you might consider visiting even for a short. We do have a very robust human factors research program. Our and others are very involved with this research. Tino and his family were here. We work hard and play hard. This is dinner at my house with my wife Anna Ray and Tino and his wife and his children, along with some residents and fellows to our departments. So here's the question that I would like you to be able to answer by the end of this lecture. we improve care for surgical patients, really for the very sick who tend to have. So there's 4 sections to this lecture. The first is an overview of human factors research. The second is a description of the checklist, which is a brief of human factors intervention. Third is an expansion on the F1 pit stop model. This is the idea that high-risk, high-reward endeavors sometimes use human factors. This includes aviation, hospitals, and F1 pit stops. And lastly, I'm going to expand on some of the research that we completed in my program. Patient tool has come up. So let's start with a comment. So this is Gary Larson. And if you can imagine, you sit down on an airplane. There's a switch right next to your seat. If you flick that switch, the wings will fall off the airplane. The comment here is that Ted here sat down and just flicked this switch and lost the wings on the airplane. This is an example of a factors intervention that should never occur. A human error by flicking a switch causes the plane to crash. And of course, for aviation, we should never have that. We should not have that in medical care. The Moto flip phone was one of the most popular phones in 2007. With that phone, you could text, you could call, you could explore the internet, you could do everything, but the user had to fit the system. It was very complicated to text, to explore the internet. The idea was that the user was forced to learn that system. In 2008, if I handed you an iPhone, you would be able to seamlessly pick it up and do all the tools I just named. So human factors research, the idea behind it is that the system should fit the user. The physician shouldn't even realize that there's a background system that is protecting his or her cases. The same goes with aviation. The same goes with almost any high-risk, high-reward system. The wrong type of human factor system is forcing the user to fit the system. If you want to improve your health care and you have some ideas and you're forcing all your users to fit that system, it does not work. So the Swiss cheese model of error causation is a frequently cited model for why catastrophes occur. It is one you should be familiar with as it's part of the human factors research paradigm. So let's go through how medical errors lead to catastrophe. Let's say it's your first day of internship. We start our internship at July 1, and you've been given a task: remove a central line. Ideally, you would be able to look up protocols for central line removal. So it's very important that hospitals have these protocols. They should be easily accessible, constantly updated, and it's important because drift does occur. Let's say you don't have those protocols. Second, so it's early in your training and you have very little supervision. It's inadequate. So there's another hole in the Swiss cheese. So each layer of protection, the protocols, the supervision and training, they're supposed to protect the patients, but now there's a few holes in the Swiss cheese. Next, communication is not encouraged at your institution. So let's say I'm about to pull this central line, I don't have a protocol, nobody wants to help me. Let's say I ask my resident, my chief resident, and they say, just go do it. And you just go do it. You don't even tell the nurse that you're pulling the central line. And let's say it's my first day, the patient's sitting in the chair. I do the central line, disconnect it, it's open to air, the patient's sitting up. There's an air embolism. The patient suffers. So this is a very common scenario when you analyze why catastrophes occur. So what do? And there's a very traditional analogy. You would fire the resident. Maybe I should be fired because I caused an air embolism. I should have known better. That's a very poorly functioning system. So this bus driver gives another example of human factors in action. Let's spend a few seconds taking a look here. Why did this catastrophe occur? Why did the crash occur? We have lots of bus drivers in Los Angeles. We need to protect the passengers. A traditional perspective says, well, this crash occurred because the driver was texting. He was looking at his phone and it caused the crash. Fire the bus driver and that will improve. But that's not really the case. We need to improve the system. We need to do it so the user, the bus driver, doesn't even realize the system was improved. So let's think a different way. Let's change your perspective. We need to have a different perspective on how to manage medical errors. We need to accept a range of human behaviors. Errors do occur in a system, and the system should protect the bus driver from crashes. The system should protect the patient from medical errors. I'm sure you saw several ways to improve this system. If you look here, the median of the road is too narrow. It will not allow a disabled vehicle to pull over. Early warning detection has been around for about 10 years, so this bus should have been signaling to the driver that, hey, there's an obstacle ahead, please look out. Elon Musk, one of our US Tesla guys, he would say autopilot is the way to go, that cars are safer when they drive themselves. And so perhaps the bus can swerve around this broken down truck on the side of the road. And then lastly, this truck looks very old. It looks like it needs to be inspected. We need to get older trucks inspected at least yearly, and we need to get the older ones off the road if they continue to break down. So if we did a number of changes to the system, it would probably reduce the crashes that occur. Review the differences between a traditional perspective and introduce the idea of a more modern perspective. We need to acknowledge that some of these slides came from my human factors colleagues. This is Doug Wegman's thinking. So a traditional perspective says we should focus on the errors and the violations of each individual. If a safe act occurs, it's because the driver or the surgeon was inattentive, lacked good judgment, was forgetful, was reckless, or even negligent. So the interventions that we do, so if I want to improve my system, if I want to improve surgical outcomes, we want to aim at decreasing unwanted variability. So we want our surgeons to be perfect. We want our nurses to be perfect. We want our therapists to be perfect. But that's not acceptable. The way that we improve our individuals is to retrain them, to discipline them, or even fire and sue them. And when taken to the extreme, those individuals who have complications, it's because they're bad people. So that's a traditional perspective, and all of those analogies need to be ruled out. You need to push those out of your mind. A more modern systems perspective is that humans make errors. This should be expected. A human factors system that's well organized will accept errors. So flow disruptions are the disruptions in the flow of patient care. These are disruptions that can lead to errors, that can lead to catastrophe. And we need to minimize them, but we need to expect them. So we want consistency in performance, but we need to allow for some flexibility. And the countermeasures are based on the assumption that we cannot change the human condition, we can change the conditions under which humans work. So improve the system around each provider. And then we need to acknowledge that the best people can make errors. So if you had a surgical complication, it's much, much more reassuring when your bosses say, well, we can expect errors to occur, we're going to improve the system around you to see if we can improve your outcomes, rather than saying, well, we're going to retrain you or fire you. So I very much encourage a new modern systems perspective. some ways, this can touch on the surgeon's ego. I know that when I was first reading about this, that I probably had a more traditional perspective, and that's the idea that when you take a patient who comes to me who's been shot or stabbed or in a car crash, it's me, it's my skills that are the difference between success and failure. I'm going to either save the patient or the patient's going to die, and it's because of me. But a more human factors perspective is that, yes, the surgeon's skills are important. What I do is important, but the system around me that can help me provide care is more important. That's like the equipment is optimized, there's reduced distractions, we have a team that works well together, that we have appropriate scheduling, and we have appropriate resources. And that's the real difference between success and failure in a patient's life. That was a quick overview of human factors. I want to talk about a human factors intervention. Frequently, the idea is when there's a problem in the system, there's an attempt at introducing human factors ideology, and the checklist is frequently introduced as one way to improve the system. I'd like you to understand that sometimes a checklist will work, and sometimes a checklist will not work, and you need to really understand the system before introducing checklists. Blondie is an American surgeon who writes frequently. He wrote an entire book on the Checklist Manifesto, expanding on how useful the checklist can be. This New England Journal of Medicine paper introduced a surgical safety checklist to 8 hospitals throughout the world. Those hospitals included a hospital in Canada, India, Jordan, New Zealand, the Philippines, Tanzania, England, and Seattle, Washington. This was a pre-post comparison, so for 6 months prior to the introduction of the surgical safety checklist, they tracked mortality and complications. The surgical safety checklist was introduced, and mortality and complications were compared. And based on the conclusion of this article, the introduction of a surgical safety checklist led to a reduction in mortality and a reduction in complications. So this New England Journal of Medicine paper is very encouraging of the surgical safety checklist. Just to refresh, the surgical safety checklist will make sure that a number of items are being done prior to surgery, during surgery, and after surgery. So items like patient's identity is confirmed, the site's confirmed, the pulse ox is written for, antibiotics are given, and so on. The idea is that the surgical safety checklist works for some hospitals, but not for others. Go to the very top line and to the very right, you'll see that the first hospital, when it compared all 6 safety indicators, pre and post, before the introduction of the surgical safety checklist, they were 94.1% performing all 6 of the safety indicators. After the checklist, they were 94.2%. So they would really change. They were doing very, very good before and after. If you go down to the 5th hospital on the 5th line down, before the introduction of a surgical safety checklist, they had a 0% all 6 safety indicators performing. And after the checklist, it didn't change. So those were 2 systems that did not benefit from a surgical safety checklist. One was doing so well they didn't need it. The other one was doing so poorly that they need much, much more than the surgical safety checklist. If you go down to the 8th hospital, the 8th one all the way down, if you go to the far right corner, they were at 0% before its introduction and 51.7% after. So they very much benefited from the surgical safety checklist. So the point here is that some hospitals will benefit, some will not. And you really need to improve your system before you introduce interventions. You need to understand the system. You need to do a deep dive into what's actually going on with the system. And I'll expand on what exactly we did to understand our system here at the end of this lecture. I want to compare the previous paper to this paper. It was a follow-up, and this was at hospitals in Ontario, Canada. So these were highly functioning hospitals. And they did a similar comparison, a pre-post comparison. This was for 6 months total. It was many, many more procedures, 109,000 versus 106,000. mortality and complications did not change with the introduction of a surgical checklist. This paper really refuted the idea that the surgical safety checklist was important. But we should know that it will help with some hospitals, it might not help with others, and you really need to understand that a checklist may make a difference after you understand the system. So now on to the F1 pit stop model. So we're fortunate to collaborate with a number of individuals who were at the very top of their field in human factors. That includes Ken Cashwell, Bill Wegman, and Tara Cohn. And Ken was actually faculty at Cedars for a number of years, and he embedded with the Ferrari team and learned more about their Formula One pit stop model. His goal was to better understand what they did during that pit stop so he could bring that over to the healthcare side and improve healthcare. So this is a 1970s era NASCAR. You can imagine they're driving around in a circle, and when they pull over, it's like stopping at a gas station where there's a leisurely discussion with the driver, the tires may be changed, there's really not a lot of teamwork or coordination here. To improve this system, you're going to need more than a checklist. Our more modern F1 pit stop, watch how well this team works. It's a highly functional team. They trust each other. If you're the surgeon and the car is your patient, imagine having this team around you, helping you work with the patient. So these highly functioning teams can provide us a lot of information on how we can improve our healthcare system. Even with highly functioning teams, catastrophes occur, and we need to better understand why they occur. We need to expect errors. So, if you break down what occurs in a pit stop, a number of items have already occurred. There's training, there's communication, there's a leader at the top of this key who's holding a red flag. They can change the tires. Every person in this pit stop can do every other person's job, but they're focused on their job. They trust each other. And it works very well. Communication is nonverbal. It's so loud that you can't hear each other. You have to communicate nonverbally. So in the upper right-hand corner, you see the gentleman with the flag. He's actually the team leader of the pit stop. He's also assisting. So we need to bring these tools into our healthcare pit stops. So we took from the pit stop model that first we need leadership. We need individuals like your superintendent, your department chair to assist with rolling out these items that work for your healthcare system. You need to have simulations. So we're very, very enthusiastic about using healthcare simulations to help us with high-stress environments. We understood from the pit stop model that pre-briefings, before you even have the car come in, you need to discuss what you're going to do. Equipment is extraordinarily important. You have to have high-functioning equipment. And communication needs to be enhanced. You need to have different ways to enhance communication. The challenge with trauma care is that there's a number of pit stops. They occur prior to the patient arriving to the hospital, in the emergency department, in radiology. There's transportation. The patient goes to the OR. Transportation. The patient goes to the ICU. We had to improve all of these areas to improve the care for our patients. So we embarked on this over a 4-year period to determine how we can improve our care. So I mentioned before that we really need to understand our system, that you don't want to start with a checklist or a rollout of an intervention without understanding your system. So we understood our system by observing our health care and discussing the care in different ways with the providers. So we quantitated what we call flow disruptions, captured their number, and we also qualitatively analyzed them. We described what they were, and then we determined how long the flow disruption caused care. We also interviewed our providers, we surveyed them, and then we reviewed our process maps so we understood what protocols are supposed to be done. And then we did a multidisciplinary analysis. Our goals at this first stage of this research was to improve situational awareness, communication, coordination, and diagnostics. So quick way, if you want to understand any system, whether it's healthcare or aviation or F1 pit stop, is to review the policies, discuss with the people, and observe what happens in practice. So I teach an undergraduate class at UCLA, and whenever we review these items, I always get back to policy, people, practice. Policy, people, practice. So what were our policies? So for trauma care specifically, we have to have a policy for care for all patients. How they're triaged initially, how they're managed in the OR, and these have to be updated quite frequently. There's new papers coming out constantly, and as part of our surgeon's role is to update these. So every couple of years, each one is analyzed, and we see if we want to change how we're managing patients. So we review these policies. Much like policies for removing central lines, surgical care has to have policies. We then moved on to our people. So this is the survey that we conducted about how we provide care to our patients. We did well in some areas. At Cedars Sinai, if you go down to the bottom one, we have high quality, reliable equipment. We performed well there. But we asked our providers, our surgeons, our nurses, our technicians, would you feel safe being treated here as a patient? We did very well with that. They thought we would. They thought they would feel very safe being treated at Cedars Sinai as a patient. We learned about areas that we did not do well. Briefings. Before this research, we just did not perform briefings. Pre-briefings, post-briefings. We did not discuss what we did or what we were going to do. We certainly could have improved that. And then another area, the first and last name of the people you were working with was relatively unknown. We were basically crews and not teams. So we didn't know anybody's name. We'd come in the ED, we'd work together, but nobody would know each other's names. We'd go to the OR, we'd work together, but nobody would know each other's names. After the survey, we actually sat down, focus groups, and individual interviews. We met with 24 nurses, 14 doctors, 27 technicians, 8 pharmacists, social workers. We asked what would be one step that would improve the trauma process. Our primary and secondary survey was very chaotic. It was an area that we did not do well in. Communication was weak across the spectrum, and our operating rooms could have improved in terms of their availability and the coordination of care there. What frustrates you most about the trauma process? Coordination. There's always something that was poorly coordinated that interrupted the patient's care. There was role confusion that a number of people were considered the captain or the leader, but nobody knew who was. The communication channels were not clear. Who was supposed to call the blood bank? Who was supposed to enter the orders? Who was supposed to contact the OR? We could certainly improve our communication. And lastly, and this was the most time-consuming aspect of this research, we observed in practice what happened with our care. So I mentioned before flow disruptions. So we can't always prevent catastrophe, but we can certainly minimize catastrophe. To minimize catastrophe, we have to minimize other aspects in care, like flow disruptions. So these are any type of pause in care or long-term hold in care, and we categorize them with communication, coordination, external sources, training, equipment factors, environmental factors, and patient factors. Also ranked the flow disruptions. So a ranking of 0 would be a flow disruption of no impact. For example, a phone ringing in the background or noise that's just in the background. That's a flow disruption. It's not impacting care, but if those flow disruptions increase a bunch, then care is going to be affected. The idea of a minimal impact flow disruption is one where, again, there's maybe no pause in care, but it requires an extra effort by the care team. So if a nurse asks me to repeat what I just said, that would be a flow disruption that scored 1. A flow disruption that scored 2 would be a pause in care, and that's less than 2 minutes. So if I have equipment that malfunctions, for example, if I have to put a lead back on a patient to get it on the monitor, that would be a score of 2 flow disruption. And the score of 3 was the really bad flow disruptions. These are the times when you request a consultant and they're supposed to be immediately available, but they're not available. Or you have a patient who's supposed to roll into the CT scanner and there's already a patient there. Those are high-impact flow disruptions. Here's some examples of flow disruptions we saw. The nurse asked the resident to speak up because too many people were talking. Another patient was in the CT scanner. It's a environmental factor where the room's too small and the x-ray tech couldn't get the machine into the operating room. We had some issues with our portable monitors malfunctioning. External interruptions, so you have to take another phone call while you're in the ER. Patient factors, we did note there was various times in care where the patients were not well sedated. And technical skills, where an individual doesn't know the job they're supposed to do, and then training. Then we mapped where the flow disruptions were occurring. We learned that patients going directly to the OR, they had a high degree of flow disruptions. Patients who were going from the emergency department to the ICU, they had a high degree of flow disruptions. So those were the areas that we wanted to focus on. We wrote this paper in the Journal of American College of Surgeons that just expanded on our flow disruptions that occurred in the CT scanner. So I imagine there's many surgeons out there who are nodding their head. Getting a CT can be very, very frightening because the patient is not well monitored, and there's not a lot you can do. We have a saying that the CT is the tube of death. We're very frightened about the radiology. What we learned is that the average time these patients were spending in CT was 30 minutes, and that seems like a lot to me. I really don't like the idea of a patient spending 30 minutes in CT. There was a mean of 7.6 flow disruptions for each patient who went to the CT scanner. And you can see with the low impact flow disruptions, those that were scored 0 or 1, coordination was actually the biggest problem. Coordinating care is really a challenge. Knowing where the patient is, where the other patients are, trying to deliver that care is very important. And again, with the high impact flow disruptions, coordination was a problem. Patient factors were also this challenge that we had to work through, that patients were going from one area to another, and they weren't well, we weren't preparing well for that transfer. Still in the time period where we were just trying to understand our system. We were understanding the system before we introduced before we introduced interventions. And what we learned that there was an average of 20.4 flow disruptions from arrival to the final outcome of the patient. So if the patient went to the OR, that would be considered the final pathway. If the patient went from radiology to the ICU, that would be the final pathway. We also learned something that was an item that was very discussed, and that was how did we do with higher severity cases, the patients who were sicker, the patients who had worse outcomes. One hypothesis that, well, we don't do well with the low acuity ones because we kind of let our guard down, but the high acuity ones, we all perform much, much better because we work as a team, and we all come together. This, in fact, was false. With the more severe trauma, we actually performed worse. There was more flow disruptions. So we certainly had to work on this. This is where we came together. We decided that we wanted to improve care for critically ill patients. We performed data collection by going through the process maps, the interviews, the focus groups, the survey, and the observations. We got a bunch of experts together, the surgeons, the human factors experts, the quality improvement folks, and this is where we started to decide on what might work to improve the system. What do we do to make the system better? Some might work, some might not work. One item that we rolled out was better training. So team steps, something that will improve communication, define roles and responsibilities, improve leadership, and manage conflicts. And this is something we decided we would put all of our residents through. We actually worked with the team steps folks and designed a system that could be completed in 2 to 3 weeks. Something that our residents, I feel like, improved how they were able to communicate and lead our patients. We have a whiteboard, so one of the challenges in the care of patients is that through the trauma bay, multiple people would ask what the patient had, or there was updates to the patient, and everybody would have to be re-updated on that. So we did different incarnations, and we just decided on simple whiteboards in all the trauma bays that had misinformation on it, that was mandated to be updated as much as possible. and then you were told to look at this board rather than repeatedly asking what was going on with this patient. Something else that we rolled out, we tested prior to introducing it on a larger scale, and it worked quite well, was pre-briefings. Pre-briefings before the patient arrived actually were very interesting. So this was on a total of 57 patients where we monitored whether a pre-briefing occurred or not. And what we learned is if somebody from the trauma team could roll through the pre-briefing, and that could be anybody, a junior resident, senior resident, or the trauma attending, would brief with the nursing team, the emergency department physician, the technicians, what they thought was going to be needed for the patient. If this was done, the time to the first x-ray and the time to the first lab draw was significantly quicker. There is a caveat, though, that sometimes you can't do a pre-briefing because the patient is arriving before you get there. So we really needed to encourage pre-hospital communication to allow for the trauma team to prepare and do these pre-briefings. Standardized our trauma bay. We realized that everybody was running around, and that by standardizing this, we did a before and after, and we saw there was less distant travel and there was less time to find resources. This was an intervention that we thought might be very successful, and that was the use of headsets, these headphones, throughout the trauma care. So you can imagine if you're in the operating room and you want somebody to bring in a suture or a book vault or some device, that maybe if everybody was wearing headsets, this would improve the flow of care. There would be less flow disruptions. So we did these simulations. We had these teams of 2, and every team went through 4 chaotic procedures. We videoed the interactions and recorded flow disruptions and the time it took to complete tasks. And by the way, we piped in very loud noise to make the users use the headsets. And we had these very technically savvy headsets that allowed multiple people to talk at the same time. What we found, though, was that the headsets did not make the mean task time more efficient. The flow disruptions did not decrease. They were easy to use, and they were very beneficial when you had a team member in another room, and they added clarity in a chaotic environment, but we didn't see an improved efficiency. There was size and weight concerns. Multiple voices led to confusions. And in reality, when you need to be heard, you would be heard. Communication could occur, and it could be just like F1 pit stops. It could be verbal or nonverbal. So, this is a paper in JAMA Surgery that we published our results after we rolled out the interventions. So, we understood our system, we decided on which interventions we were going to roll out, and then again, we went through these observation periods where we have these PhD students and these medical students follow these patients 24 hours a day, 7 days a week. And we realized that we were able to improve efficiency. We were able to get patients out of the trauma bay, out of the CT scanner, to the OR more quickly. We reduced flow disruptions. Importantly, with the high level flow disruptions, we reduced the efficiency. You can see on that graph there from time in the ED almost being cut in half. And in the high-level traumas, we saw a reduction in length of stay. We were getting patients to their consultants quicker, we were coordinating care more quickly, we were getting them to CT, and it dropped a half day off their stay. We also were getting patients where they needed to go. So we had open beds in our ICU, but the flow of the patient would go from the ED to the CT scanner and back to the ED. And we needed a simple checklist for everybody to understand if you had any patient who was potentially sick. If you heard from the pre-hospital coordinator that patient was coming in after a high-speed car crash, you could request an ICU bed then, because you can always reverse that request. Requesting an ICU bed was something that should be done, even if you're just suspicious that it's necessary, it could be reversed. We also had to make sure the handoffs were occurring between the nurses and the doctors. And we really dropped the amount of time that these patients who required ICU beds, we dropped the amount of time they stayed in the emergency department. We also figured out that we could reduce potentially avoidable ICU admissions and reduce these patients who needed to leave the ICU stay. Sort of broke down why patients were coming to the ICU and leaving less than 24 hours, and why patients were coming to the ICU and they were staying much longer than expected. By understanding the system, we were able to actually have more ICU beds available. And we were able to, over this period, decrease our potentially avoidable days by about 30%. That brings us to the question that we asked at the beginning of this lecture. How can we improve care for surgical patients, particularly for the very sick who tend to have the worst outcomes? Well, there's a number of answers to this question. Every system is different. You have to take a modern systems approach. A traditional approach that you blame the person who makes the error and you don't improve the system, that's going to lead to continued complications, continued catastrophe. This idea of understanding the policy, the people, and the practice is important. Understanding flow disruptions and reducing flow disruptions, not just focusing on the complication, but on the disruptions of care that occurred before the complication. Be very careful with your interventions. They have to be thoughtful. Oftentimes, the tail wags the dogs. The interventions are rolled out before the system is understood. I find that administrators frequently have this idea that there's shoot from the hip, let's introduce a checklist, and it doesn't actually help the system. If anything, it makes working for clinical care much harder. If you want to look at two areas that always need improvements, communication and coordination. Communication between providers and coordination of care. There was a number of individuals who worked on this research. I need to acknowledge them. Our human factors experts were certainly terrific in helping with this research. My chair, Bruce Squirts, was the PI for the grant that supported this research. So you can imagine this crane fell down and the flow disruptions that occurred after the crane fell down. It's pretty catastrophic. Some flow disruptions occurred. My family says, good morning to you all. Thank you for your time. That concludes this presentation.
Okay, awesome. Dr. Ley, thank you for your excellent speech. Now you talk about the choice model or checklist and F1 pit. I remember you showed me this F1 pit the first day I arrived at your office. Very awesome. And you share your awesome human factor research. I think we all get a lot from this. And may I allow me to invite our superintendent, Professor Chichiwan, to say some words?
Hey, Professor Ley, this is Chichi. First, I would like to give my best sincere appreciation to you for accept Tino received the fellowship training in your departments. Los Angeles is a great city. Terrific foods, culture, weather, people. And I heard about the reopen of since yesterday, fully. So congratulations. Tino now is charging the surgical ICU, and in the near future we're gonna have upgrade the SICU, include 60 beds, CVS ICU, general ICU, and trauma ICU. The ICU in Cedars is one of the best ICU in the US. In our department of surgery, we spend like more than 50 time in surgical room, focusing for the MMM study. So today's presentation is fully achieving the goal of the first degree of surgical service, and I believe the presentation will inspire and draw more young surgeons to dedicate to ICU service. So I truly hope more cooperation between Cedars and高雄长庚. Okay, thank you very much. Thanks.
Thank you.
Now we have 127 audience online. We are going to the Q&A time. Does anyone have a comment or question for Dr. Ley?
Hello, Professor Ley. I'm Lutheris from our trauma team. Here are two questions that are concerned. The first, how to distinguish personal error from system failure. And the second, from your point of view, what are the most key issues to improve communication between ER and OR to ICU? Thank you.
Thank you for those questions. I really appreciate that. I'll I'll just start by acknowledging that Superintendent Xixi Wang is very open-minded. He trained out here and was able to help us with our system here, and then he's developed the system there, and then he sent Tino back here, and I think that's very, very open-minded and allows for collaboration, and Tino did excellent work while he was here. So let's start with your second one. The communication between the ED and the ICU can be challenging. So I would acknowledge that first you have to understand the system before you try to improve that the communication is, it always needs to be improved. We tried to roll out an app that tracks messages between all users, and that was very successful, but I think the first thing is to really do a deep dive into your system to understand why there's communication challenges. Is there end of shift communication that's starting to cause friction between the teams? Do you need to have combined simulations with your ED nurses and your surgical nurses, includes your surgeons and your ED doctors? Those are potential interventions that you can roll out. Leadership training is certainly excellent for everybody involved, but for all I know, the communication just needs to be improved because the Wi-Fi needs to be improved. So I think the first step is really understanding your system and then producing some thoughtful interventions. For your first question, I think human factors and safety is very interrelated, that human factors can improve patient safety, it can improve efficiency, it can improve cost, it can improve culture. So I think the place to start is what you're trying to improve and then focusing on that with your human factors interventions. Thank you for those excellent questions.
Hi, Professor. I'm Dr. Wei. I come from the trauma department. I'm a newcomer. This is the second year for me. I have some question for the speech. I just wonder, is there a standard procedure in terms of flow disruption? I mean, what is the goal? And the other question is, how do you choose a topic for human factor research?
Yeah, thank you for those questions, Dr. Ray. I appreciate that. So flow disruptions need to be captured. You need to understand what's occurring. You know, if you're doing anso low colon anastomosis and your phone rings in the OR and the nurse says, you know, Dr. Ley, I need you to take this call, that creates significant challenges. You might throw a stitch where it's not supposed to throw, and so that's a significant flow disruption. So that's like having pauses in care where you are completely protected from outside intervention is important. So I think you need to capture flow disruptions. You know, a few times during this lecture, the PowerPoint tool kept asking me if I wanted to edit my slides. That's a flow disruption. So a well-functioning system like has been designed with this communication will allow us to overcome that, but it can be catastrophic if I can't figure that out. So some teamwork training is also very important to help with flow disruptions. I think your second question was probably the most interesting because we can expand on topics for human factors research. I think that Taiwan as a country probably did the best worldwide of all countries in terms of prevention of COVID. I think comparatively, as a system, the US actually did very poorly with prevention. It became politicized here. So what worked in Taiwan wasn't working in the US and probably vice versa. As the Delta variant has come out, it's become more obvious that we need vaccinations. So those countries that did well with prevention of COVID, they need to improve vaccinations, and I know Taiwan's doing a great job with that, so congratulations. Fortunately for the US, we actually did well with vaccinations in some ways because we had earlier access. So these are topics for human factors research. I think that, and I'm very sorry for your train crash. That was a very tough time for everybody in the world to see that. I think understanding why train crashes occur, that we've had in the last 10 years, 3, where there's been different reasons for why they occurred. One was because there wasn't coordination when a truck got stopped on a track, and the communication to get that truck off was not good. So we had a number of these items, and you have to do a deep dive for these human factors areas occur. So The topic for human factors research is whatever you like. You could start with that first question about communication between ED and trauma, which certainly needs to be improved, or you can start large at a bigger scale with your new ICUs. Thank you for the question.
Okay, any other question or comment? Okay, it's a very perfect, very awesome speech, and Saturday. This is the certificate of our appreciation for your excellent lecture. I think we will send you the physical certificate as soon as possible. And you know, we just passed the Dragon Ball Festival. The one you know? Okay. I think you missed something, but never mind. We hope after the pandemic, you can come to Taiwan, maybe host you and your lovely family.
Thank you very much.
Okay, we look forward to seeing you soon. And now, Professor Chishiwa want to give you the award. Let me show the picture. Eric, are you going to accept the award? Do you see Chichiwang? He's going to give you the award. This certificate. Can you? Give the hand? Yes, very good. Okay, perfect. We look forward to seeing you soon. Thank you.
Thank you.
This has been delightful. Thank you.
Thank you.
Thank you.
Okay, bye.
Bye.
Okay. We'll be in touch.
Thank you.
Bye.